Good afternoon. Today we have a 2-month-old infant who's coming to the clinic with her mother for a primary care visit after they had a home birth delivery, and the mother expresses concern about poor feeding, poor growth, and tachypnea. So the mother is concerned about how little her child looks and describes recent changes in her feeding patterns. For example, the child is now taking longer to eat, about 45 minutes. She's eating only every 4 hours as opposed to 2 to 3, which was her normal. And she occasionally dozes off or sweats while breastfeeding. The mom also describes some lethargy, some tachypnea, and episodes of the infant gasping for air or shortness of breath. There's no cyanosis, no rash, no changes in stool pattern consistency or frequency, no constipation, and no vomiting. So that's looking good. As far as past medical history, she had an uncomplicated home delivery with the baby born at 38 weeks gestation at a normal and appropriate birth weight. The mother is 45 years old, and so it does have an increased age for giving birth. So that's something to think about. There also was a history of a URI in the infant, but there's no documented information about that. No vaccinations have been initiated, and no chronic illnesses or hospitalizations have been noted since the delivery. The infant is awake and alert on physical exam, but height and weight measurements reveal that she is small and short for her age. Vitals are as follows. She's afebrile with a temp of 98.5. Her heart rate is 175 beats per minute, which is slightly tachycardic. Blood pressure 65 over 50. Respiration rate is 58, which is tachypneic. Her O2 sat is good though at 98% room air. And so for her height, she is 45.5 centimeters, and the normal for a girl at 2 months old is 53.2 to 60.9 centimeters. So she is small, and then same thing for weight. Her weight is 3.71 kilograms, and the normal at 2 months should be 4 to 6.5 kilograms. So she is small based on height and weight parameters. On physical exam, there are some significant physical features that are noted. She has a soft and flat anterior fontanelle with palpable fissures that are upward slanting. She also has a depressed nasal bridge. She's tachypneic with mildly labored respirations with some accessory muscle use. Auscultation reveals that the lung fields have symmetric or bilateral scattered crackles. Her heart rate, she's tachycardic with a regular rhythm and normal S1, S2. There is a holosystolic murmur heard at the left lower sternal border that is notable. The patient has equal and appropriate muscle tone and posture in the extremities, so all good there. And all other review of systems and physical exam findings were relatively normal. They were normal. The problem list, just to review, we have the tachypnea with the crackles on auscultation of the lungs. We have the report of the gasping for air and the accessory muscle use with respiration. We have that holosystolic murmur at the left lower sternal border. We got slow growth, poor feeding, lethargy, that recent URI, and then physical features consistent with Down syndrome. So the infant presents with the classical features of Down syndrome. This, along with the mother's increased maternal age, is associated with an increased risk of having a child with Down syndrome. So we're thinking that this child probably has Downs, especially because she wasn't born in a hospital where it could have been diagnosed right away. Poor feeding and poor growth can be associated with several different differential diagnoses. The absence of a fever rules out something like infection. The lack of significant GI symptoms like vomiting, changes in stool, that fun stuff rules out things like GERD or gastroenteritis. Some nervous system conditions can cause poor growth, like cerebral palsy, but the normal muscle tone and posture and strength rules that out. Um, Also, the fact that the child was born at 38 weeks gestation and at a normal birth weight uh, indicates that she probably should be having normal growth, because sometimes premature children or children born with low birth weights continuously have slower growth patterns. So another thing that I'm thinking about that could be the cause of this is a cardiac abnormality. Kids with Down syndrome do have an increased risk and history of having congenital heart defects. So that's pointing me in the direction, along with the fact that she has respiratory symptoms and something respiratory going on, because the heart and lungs and all that's all connected. So I'm leaning towards some kind of cardiac issue here causing her symptoms. Many congenital heart defects have similar presentations. So the diagnosing is based off techniques like the echocardiogram or an EKG. That really sets them apart. But differentials right now that I'm thinking is the ventral septal defect, the tetralogy of Fallot, the tricuspid atresia, transposition of the great vessels, truncus arteriosus, and a bunch of other stuff. So the big thing, though, that we heard on exam was the holosystolic murmur, heard best at the left lower sternal border, and this is indicative of ventral septal defects. The tricuspid atresia also is associated with this type of murmur because it normally has a ventral septal defect with it. But with tricuspid atresia, it's normally you hear just one single S2, but we heard a normal S1 and S2, so that's slightly ruled down. And then the tetralogy of Fallot, that also has a holosystolic murmur, heard best at the left upper sternal border. So still something to think about with our differential. So in summary, we have a 2-month-old female suspected to have Down syndrome with an underlying cardiac abnormality causing her poor growth, poor feeding, tachypnea, and this heart murmur. So what's our plan here? We definitely need some diagnostic testing, like I said, to determine the direct cause of this cardiac congenital defect. So I would like an echocardiogram. I'd also like an EKG. I'd like a chest x-ray to investigate those scattered lung crackles. I'd also like a rapid blood test or a karyotype to diagnose for Down syndrome. And then I'd also like a CBC and CMP just to assess for anemia or any other electrolyte or hormonal abnormalities, because this might not have occurred because of her home health delivery. As far as management, so if it is a ventral septal defect, what's interesting about these is that actually they can most resolve spontaneously within the first 2 years of life. So that's why we want the echocardiogram, though, because the echo will tell us the size and location of the defect and if surgical intervention is needed. I would refer to a cardiologist so that we could do this together, and so we could decide if surgery is going to be needed. I'd also refer with consult with the cardiologist to decide if any medications are to be given. In this ventral septal defect, some different medications we could give are diuretics like fezanamide, the ACE inhibitor like lisinopril, or a beta blocker like digoxin, just to help with all the cardiac abnormalities going on. As far as what we want to do for the management of Down syndrome, I'd like to do some additional screening because they are at increased risk of several different disorders. And that's why I kind of want that CBC and CMP too. And then most children with Down syndrome will need special education programs and different types of therapies like physical therapy, occupational therapy, speech and behavioral therapy. And starting at a young age, I know she's very young, but starting at a young age can be associated with better long-term development. I would also provide additional resources and information about Down syndrome to these parents because it is a lifelong condition that they will need to help with for the rest of this child's life. And then finally, I would just like to recommend that the child gets vaccinated because she has not received any yet. So that's what I would also like to do at this visit. So that's my presentation. I hope you enjoyed. Sorry I'm outside. There's people being loud and rowdy in my house, so had to get out. So thank you for listening.